Hello, everybody. Greetings and welcome, participants. This is Leslie Lomo from the University of Utah here in Salt Lake City, returning back again to introduce the next speaker for the Africa Calls series. I'm thrilled to introduce one of the rising stars in our cytopathology field, Dr. Rema Rao. Currently, Dr. Rao is an assistant professor of pathology at the Albert Einstein School of Medicine and an associate cytopathologist at the Montefiore Medical Center in Bronx, New York. She obtained her primary medical degree and initial training in ophthalmology. And after transitioning to the United States, she completed her combined anatomic and clinical pathology residency training, as well as cytopathology fellowship training at the Massachusetts General Hospital in Boston, Massachusetts. She served there as an attending pathologist at the Weill Cornell Medical College for several years before transitioning to her current position at Albert Einstein School of Medicine, where she is also currently the director of their cytopathology fellowship program. She has published several peer-reviewed articles and book chapters to date, focusing on various cytopathology topics with a focus on pancreatic and salivary gland cytopathology. And so she will be speaking with us today about selected solid and cystic pancreatic lesions and the role of endoscopic ultrasound-guided fine-needle aspirations. Thank you, Dr. Rao.
Thank you, Dr. Lomo, and thank you, Dr. Milner, and hello, everybody, and welcome to the talk. Apologies for the delay. So without further ado, I'm going to just jump into the topic. All right, so moving on. Topic for today is pancreatic cytology. We're going to talk about the role of endoscopic ultrasound-guided fine needle aspiration, and we're going to talk about some entities. Because of the nature of the timeline, I'm not able to address all the pancreatic entities we see, but we're going to talk about some select lesions. The outline of the talk is fairly simple and straightforward. We're going to discuss some basic anatomy and histology, but more so kind of dwell into the role of ultrasound-guided FNA and a little bit more on the cytology of select solid and cystic lesions, just brush up some ancillary techniques and overall approach to pancreas cytology. Anatomy of pancreas, we all know it's retroperitoneal organ sitting right in between, retroperitoneal organ sitting in between with the first and the third part of duodenum, kind of sandwiched there. And it has both exocrine portions and endocrine portion, the exocrine portion being composed of the ductal cells and acinar cells. And acinar cells is probably the dominant type of cells that we see in a pancreatic benign or normal pancreas. And the endocrine portion is largely composed of the islets, which we see which we barely see unless there is some kind of a pathology there. Moving on to histology, so acinar cells compose the large cell population. They are these pyramidal cells with granular cytoplasm, the purplish pink granules that we see, and they are connected by the intracollated and the intercalated ducts to the main pancreatic duct, which is where all the secretions end up going to. So that's just about, so what we see in a normal pancreas or benign pancreas is more largely these acinar cells and a few ductal cell groups in between. Some of the methods of sampling, I mean, pretty much these two are the standard methods of sampling pancreas, right? We, as cytologists, cytotechnologists, we largely see the endoscopic ultrasound sampling or the EUS FNA samples in our practice. And when it comes to, strictures and stenting, we do see brushings through the ERCP or the endoscopic retrograde cholangiopancreatography. I think this slide kind of conveys a lot about what we see in cytology and EUS FNA. In that pancreas cytology cannot be done as, just solo. There is no way, at least in my experience, that we can put a slide of pancreas on the, on the microscope of a lesion on the microscope and just say, hey, this is exactly what it is. Yes, one could argue that in straightforward adenocarcinomas, you could do that. But even then, what I've learned in my experience is to always use imaging reports to guide me to my diagnosis. And therefore, pancreas cytology and EUS FNA, which is probably the larger way of, modality of getting pancreatic lesions on the needle, is probably a very important tool for cytopathologists to diagnose pancreatic lesions. Therefore, pancreas cytology and EUS FNA make for a perfect relationship. And I'm sure in your practices, as well as in mine, we have this really good relationship with our endoscopists, and we actually discuss these cases when we hit a hard differential diagnosis, which is fairly easy in a pancreas cytology world. So always keep that in mind. Having a good relationship with the endoscopist is fairly, is very important. Knowing the endoscopic features, some of the features that are important in some of the lesions are very important in arriving at a diagnosis. So let's go on to why exactly EUS-FNA, over all the other modalities that used to exist before, but why has EUS-FNA taken off? It is because it is the preferred method of sampling over core biopsies, right? In those days before, a lot of pancreas lesions used to be, CT guided and core and so on, but EUS-FNA has kind of changed that trend because core biopsies has its limitations. You're actually poking through a good bulk of pancreatic tissue, and that could by itself incite pancreatitis and other issues for the patient. So here comes a very fine needle able to do that job perfectly well. And so that really, really is helped us, it helped the pancreatic cancer world a lot. And we're able to acquire, fairly good diagnostic accuracy through the fine needle. It allows for biopsy of even very small lesions, right? Less sub-centimeter lesions can be sampled by this method. And also EUS-FNA, unlike a trajectory of a longer needle path, uses a very short needle path, right? And because you're literally going to either through the stomach or the duodenum to hit the target. So your needle trajectory is really short. And that sometimes, is a very valuable thing to have because it can reduce tumor dissemination. And the lymph nodes or any lesions around the pancreas can be sampled for staging purposes as well. And it also allows, and that's a very important point for EUS-FNA, is that it allows material to be aspirated from cystic lesions. And we largely rely on these ancillary techniques to arrive at a complete diagnosis. So it allows for fluid analysis and these days molecular studies as well. So the approach to pancreatic tumors is either through, if it's a head, and it's very important to know these as cytopathologists because, depending on where the lesion is, if it's in the head of the pancreas or the uncinate, or if it's in the body or the tail, one can determine what the approach would have been. And that is very helpful because if we are seeing sample of largely GI contamination, and which largely looks like a duodenum, but so you know that this was a head lesion, right? And sometimes GI contamination can mimic well-differentiated adenocarcinomas and vice versa, in which case it's very important to know, is this really gastric foveolar type epithelium from GI contamination, or is this tumor? So one of the ways of really trying to differentiate that, besides cytomorphology, is also knowing the approach to the pancreatic lesions. So here I want to just stop a bit and just want to ask the audience if this pace is fine. What do you guys think? Is this okay? Or am I going too fast, too slow?
You can comment in the chat. Let us know if Dr. Rao's going too fast or too slow.
Sure. Thank you so much, Dan. All right, moving on. This is I'm just trying to show you the different ways the probe is placed in relation to the ultrasound field. This is the radial array where the probe or the endoscopic probe is placed perpendicular to the field of the ultrasound field. So you see this is more of a cross-sectional view. And what are the advantages of doing that? Well, we can see larger lesions because the range of this is pretty large, up to 12 centimeters. One can visualize lesions very well, like for imaging purposes, and define the lesions and their depth. But trying to do a procedure with this in the radial array is probably a challenging one because the needle path is not well visualized. So one can use this for looking at lesions and the imaging characteristics. The linear array is what we use as a tool. The endoscopist uses a tool to go in and sample the target lesions. It's more of a planar, in which in the sense it's more parallel to the ultrasound field. So the needle trajectory is easily viewed, and it allows for a good biopsy. So this is more of a therapeutic when you want to aspirate a cyst and you want to completely see it resolve or something like that. You want to use this, and even for just regular FNA aspirations. The endoscopists kind of go back and forth between these techniques to get an ideal sample. I do want to introduce shock core because the EUS FNA has kind of made waves from where we were to where we are right now. And there used to be a time when core needle biopsies was absolutely, is still absolutely a no-no. And then we did pancreas EUS FNAs with just the needle and aspirating. But we've come a long way with some of the changes. We've involved new techniques in the needles by itself, where, like, for example, this is the more latest innovation in the EUS FNA world, which is the shock core needle, which actually has these, as you can see from the image, has these cutting heels and 2 axis tips, one for the sharp for the axis and the other to just catch the tissue. And so what is the advantage of it? This is one needle that goes in, it does the fine needle aspiration, and it also is able to take a little bit of a core, which is probably not a thicker core, but a thinner core to help further evaluate this lesion. So many a times, especially in our practice, what we tend to do is we use this, when endoscopists use this, they do the FNA and they provide us a sample, and they go in again and try to get a little bit core, which we try to use, which we use for our cell block preparations, and we view that. So it has been fantastic trying to use both the FNA sample and specimens from shock core. So from EUS FNA, we tend to, this is what I mean by having that perfect relationship with the endoscopist and forming a great team, as well as knowing how to read a report, because there's a lot of valuable information that is conveyed by EUS FNA for pancreatic lesions. And most importantly, it's important to know where the location is, right? Because there's certain lesions that are dominant in the head, and there's certain lesions that are dominant in the tail. Not 100%, but it's very helpful. And always helpful to note definitely helpful to know whether it's a solid lesion or a cystic lesion, and what is the size, right? What is the size of the lesion? Contours, is it an irregular contour, which we tend to see in adenocarcinomas and chronic pancreatitis, or is it smoother contours, right? Is there any adjacent invasion? Then slam dunk, we're looking at something malignant, right? And also lymph node status. If it is, if it's something that's already gone out to the lymph nodes, and especially in cases of mucinous cysts, it is very important to note if this cystic lesion that one is seeing in the pancreas is either connected to the side branch or the main duct. And that is such an important information that I really look for when I'm looking at a mucinous pancreatic cyst, because that tells me a lot that I'm looking at either a neoplastic, an IPM, and if there's a relationship to the ducts, and suggesting, at least in my report, if it looks like a neoplastic mucinous cyst on cytology. How are we doing well with EUS FNA? We're doing fantastic. Actually, the pool specificity is about 98%, very, very high specificity, and a pretty good sensitivity of 85%. In that, the diagnostic accuracy of EUS FNA is high for pancreatic carcinomas and is absolutely essential for its assessment. And it's become such an important tool. I don't know how many of you use adequacy assessments in EUS FNA. It's definitely institution dependent. In our institution in Albert Einstein and Montefiore, we do use adequacy assessment. And it's been pretty well known that up to a fair number of FNAs, right, up to 30% in some papers, without a cytopathologist are non-diagnostic. So that's a good chunk that is non-diagnostic when adequacy is not performed. So that is why we tend to use cytotechnologists on site to evaluate the EUS FNA samples and guide the endoscopist for better sampling. There are other literature out there as well, which tells you that adequacy assessment has absolutely been valuable. There's one study here, Iglesias Garcia, that tells that the inadequate samples, as you can see, the numbers are so largely different. With on-site pathologists, the inadequate samples is virtually nothing, and with no pathologists, they had close to 13% inadequacy. Similarly, there are, this study shows unsat samples were far reduced with an on-site pathologist versus no. So there is a tremendous role of adequacy assessment in EUSFNA, and I personally experienced that as well. So why is it important? Because obviously, if we are able to get the lesion in the first shot, then the patient doesn't have to go through this procedure again. There is no added cost again. And so it's a very cost-effective way of decreasing additional unnecessary procedures. It definitely increases the FNA yield, which is why we highly recommend it. And also when there is someone on site, especially when it comes to lymphomas, it's very important to have that person triage a specimen for flow cytometry or cell bulk preparation and so on, and therefore make this whole procedure more effective. Well, if you don't have adequacy assessment in your departments or wherever you work, I think it's highly recommended at least to go for 4 to 5 passes for solid pancreatic lesions to get adequate material. Triple test approach to EUSFNA is what I'm trying to say by that is you have to approach pancreas cytology not just by looking at the cytology only. It's a 3-pronged approach: clinical, imaging like EUSFNA, and cytology plus its ancillary techniques. So it's like 3-step approach to properly defining and diagnosing pancreatic lesions. So anybody's assessment of a pancreatic FNA needs to begin before slide reviews. Even before you're putting the slide on the microscope, and I tell these to all my fellows, even before the slide, if you start reviewing the slide, you really should know about the patient really well, and that helps guide the diagnosis. I'm not going to dwell on this. We all know that these are what we commonly see in benign pancreatic aspirates. This is just a nice ductal group, honeycomb. And one way I try to teach my fellows is that if you have a car and you're trying to navigate through this, if it goes easily, see like here, there are no speed bumps along the way, there are no obstacles, that's probably a good sign, right? In addition to the NC ratio. So a nice honeycomb structure is what we expect in a ductal group, and very important. And why is this? Because mucin in ductal group, ductal cell is pathology by itself, right? So technically benign ductal cells do not contain mucin. Another thing is also when you think of ductal cells and there's a lot of mucin, you'll have to think about GI contamination also if it looks very benign. So remember, benign ductal cells do not have mucin. Which is why it's important, because sometimes when you see increased numbers of what looks like benign ductal cell groups, the pitfall could be that it could be a well-differentiated adenocarcinoma. Unlike chronic pancreatitis, you tend to see increased ductal groups, but really there are not a lot of lesions where you should see very well-defined benign ductal groups. So when you see a lot of that, you may want to step back and see whether you're seeing anisonucleosis, irregularity in nuclear membranes, hypochromasia, and so on, and the drunken honeycomb as we described, where these nuclei are kind of right next to each other, overlapping, irregularity, to differentiate this from a well-differentiated adenocarcinoma. All right, acinar cells are the largest population we see in a benign pancreatic aspirate. And acinar cells are, as I described earlier, are pyramidal shaped cells with a apical nuclei, basal cytoplasm, which is purplish pink in a nice Stiffquick stain. This is a Pap stain, which doesn't show that. And the nuclei, they tend to have small prominent nucleoli, but they tend to be aggregated like grape-like clusters, as you can see in this image on the top. So anything that is tight in cytology is good, right? Anything that is loose and kind of falling apart is bad. So I use that a lot when I'm looking at acinar lesions, in that these are all very nice and tight grape-like clusters and tend to stick together tightly, in which case it's very reassuring that they're benign. And they also come off as long, big sheets when it's benign, unlike smaller ones when it's malignant. So, potential pitfalls are, on the left is the normal acini, on my left is the normal acini, and on the right could be a neuroendocrine tumor, right? Because they do have an SNR-like morphology. What do I mean by SNR-like morphology? In that they can tend to form these microacini-like look, the rosetting, the acini-like look, and they can have, you know, this granular cytoplasm. So it could mimic a neuroendocrine tumor, but one has to remember that SNR, normal SNI tends to be tighter. They have this grape-like clustering, and they don't really fall apart, not many single cells, not many bare nuclei in the background. And here's another potential pitfall as well. So I'm sure I'm not going to ask you questions because we can't have this interactive thing. But if I gave this talk in my at my institution, one of the things I would ask the residents and the fellows is to highlight which is what. And it can be difficult sometimes. What we're seeing is the normal SNI on the top, and to the on the sides are the SNR cell carcinoma, right? And those are not easy. So as you can see, they do have this kind of clustering, but you can see the NC ratio is fairly high. And you know, you can see the nuclei is pretty atypical compared to your benign acini. There's a lot more cytoplasm here and so on. So we'll talk a little bit more about it later, but I just wanted to bring this in attention to you. GI contamination can be also a struggle when it comes to pancreas FNAs, especially the gastric cells, which contain mucin, and which is largely seen when in the body tail lesions when the needle goes through the stomach. So one thing to remember about gastric cells are these foveolar type cells. They have mucin in their upper third. It's like a cup-shaped mucin in the upper third. And that's something to remember. They are all basally arranged. Mucin in the upper third does not have rush border like duodenum, and does not have like this thick neoplastic mucin in the background. So if it is a GI contamination, the background is largely thin, watery mucin. So when you're seeing thin, watery mucin and you're seeing these foveolar type cells, remember this is most likely a GI contamination, especially if the lesion is in the body and tail. And always refer to your endoscopy report. All right. I'm just looking at the time just to make sure. So this is what I mean when I'm talking about mucin in the upper third. See, it's a nice cup shaped. It's very analogous to what we're seeing on histology, the nice cup shaped mucin. Duodenal cells, on the other hand, are seen in a transduodenal fine needle aspiration. And when do we do transduodenal aspiration? When the head lesion is in the head of the pancreas. So the needle path will be through the duodenum, right? So one thing to differentiate between gastric cells and duodenal cells is that the duodenal cells contain goblet-like cells, which are these spaces within them. And I'll show you a picture. The cytoplasm does not contain mucin, so it is non-vacuolated, and it has a brush border. So it is going to very much look like this, and I'm sure all of you know this. So you see the nice brush border and these empty spaces, which are these goblet cells. And as you can see, unlike a cup-shaped mucin in gastric foveolar epithelium, you do not see that cup shape. It's a nice honeycomb without any vacuoles. Where literature, how do we differentiate? This is going to be the hardest part. I think one of the hardest part in pancreatic cytology is to actually trying to differentiate between what is benign ductal cells, what is GI contaminant, what's actually a well-differentiated pancreatic adenocarcinoma. And I think I highly rely on morphology and EUS FNA report to help me guide through this. And I've personally not used B72.3 in my practice, but there is literature out there that suggests that B72.3 can be used to help differentiate these, with the benign ductal cells being completely negative and GI contaminants being positive, with the perinuclear staining, whereas pancreatic ductal adenocarcinoma shows nice cytoplasmic staining as well. This is where the challenge lies, right? Especially when we're talking about pancreatic cystic lesions, right? The different phases of mucin. So this has been, during my fellowship, one of the hard things to grapple with, but I think once you get the hang of it, it gets a lot easier. So just seeing mucin in the background in a cystic lesion that has a connection with the duct or is in the main duct is enough to actually flag for a neoplastic, mucinous cyst. So what is the kind of mucin that we look for in a neoplastic mucinous cyst? It is thick. It has to be colloid-like this image shows with the diff quick. thick, stringy, colloid-like. And if it is a cyst, it will have cyst debris in the background, like mucophages, macrophages. It can sometimes accompany ductal cells with varying rates of dysplasia, either low grade or high grade. So that is your neoplastic mucin. Whereas a non-neoplastic mucin is thin and watery, and it's always accompanied with GI contaminants. So that's one way of kind of differentiating. It does not have cyst debris in them. If you look for macrophages, you're not going to find it in there, but you're going to see a lot of GI contamination. Thin watery mucin doesn't have that nice thick edge like a colloid here. And mucin is something, very challenging, because diff-quick stain is probably the best stain that highlights the mucin really well. But in the modern age, we're looking at liquid-based preparations where mucin is probably a lot more challenging, like as we see on the far right. That is how mucin looks like in a liquid-based preparation. So something that comes with practice and experience and to look forward to. There are potential pitfalls. So all I'm trying to say is pancreas cytology. I'm sorry, I just got muted, but I'm going to unmute myself. All right. So there are potential pitfalls in pancreatic cytology, and some of these I've listed are the pitfalls. So just based on this, you can see the challenges, right? To the right and to the left, they pretty much look identical. But to the right is my right is a well-differentiated adenocarcinoma, and to my left is a PANN3. And this was aspirated in an EUS-FNA sample, and it was interpreted as suspicious for malignancy, which is a good interpretation. And when the pancreas came out, there was a lot of pannin with no invasive tumor. So you can see one of the ways to differentiate that is adenocarcinomas always look for cellularity. Without cellularity, never call something malignant. Pannins, on the other hand, is a hit or miss. You would find very few groups with this very largely malignant looking cells, but there are very few groups. And if you see that, suspicious is always a better call. So looking more at the solid masses, and I think we're doing well on time. So some of the solid endoscopic features of solid pancreatic masses is what we're going to look at. I'm not going to be talking about all these entities in the interest of time, but I'm going to be talking about a few of them. So always assessment of solid masses or cystic masses or anything in cytology, as you all know, begins with a low power image and a high power, right? So we're looking at the background to assess what are we looking at in the low power? We're looking at the background, right? Is it necrotic? Is it cystic? Is there mucin in the background? And we're looking at the cellular composition there. And to call anything really neoplastic, you want to have some cellularity, especially if we're going to call it malignant. Just seeing few cells does not render a diagnosis of malignancy. So in the low power, for a malignant diagnosis, we need to see more cellularity, we need to see disorganization, and occasionally necrosis in some cases. And then you go on high magnification and look for nuclear abnormalities, like the ones we are worried about are the ones that show nuclear hypo or hyperchromasia and membrane irregularities and anisonucleosis, which is the variation in nuclear size of at least 1:4. Very helpful in pancreatic malignancies. So pancreatic adenocarcinomas, as you can see on EUS-FNA, tends to be very hypoechoic, right? They are darker signals. So as you can see, as compared to the surrounding solid organs, this tumor tends to be darker. So they are hypoechoic. They're not anechoic like a cyst. A cyst tends to be anechoic in the sense virtually doesn't have any signal through it, so it's dark. But solid lesions tend to be hypoechoic, in which there is some texture, echogenic texture with it, right? So what is the other lesion can mimic this in an EUS-FNA? Well, it's a chronic pancreatitis. Chronic pancreatitis can have exactly the same look, hypoechoic look. And that is why it is really challenging to differentiate these two entities on just EUS-FNA alone, right? And so to your right is a nice gross specimen of the pancreatic adenocarcinoma. And you can see it has such irregular tumor outline, irregular gross outline, and has that solid tan pink, fleshy, not really tan pink and to brown consistency or texture. Imaging and findings, like we discussed, it's a hypodense or hypoechoic mass with irregular borders, and the remainder of the pancreas could be atrophic, depending on the duct involvement, and it may involve adjacent structures if it invades into it. There are many different variants of pancreatic ductal adenocarcinomas, but the one thing in cytology is we just have to call it malignant, and that should be enough. We don't really have to go trying to differentiate these different variants between each other. Some of the criteria we use for diagnosing pancreatic adenocarcinomas are these major and minor criteria. The major criteria is all these four, as I've highlighted, which largely looks at the nucleus, the nuclear membrane irregularity, crowding, anisonucleosis, and irregular chromatin. And some of the minor criteria are nuclear enlargement, single epithelial cells, mitosis, and so on. And I think this is something you're all familiar in your practice. Adenocarcinomas, and this is actually, yes, slam dunk adenocarcinoma. Why do I say that? Because everything is there. Whatever we're looking for is there. There's background cellularity, right? There is so many cell groups in here. There are single cells, there are smaller clusters, there are larger clusters. And then the background, as you can see, is kind of debris-like background, which is all necrosis. So if we see this in a low part, our antennas are up thinking of adenocarcinoma. On a higher magnification, we do see this very drunken honeycomb look. It's a very nice term that's used to talk about how to differentiate a GI contamination or benign ductal cell groups, which tend to have a nice orderliness to it, like a nice honeycomb, to a well-differentiated adenocarcinoma, which has what we're looking at, a drunken honeycomb. What do I mean by drunken honeycomb? It basically is the nuclei between each other don't respect their boundaries. They kind of, are quite close to each other, overlapping, and so on, which makes this honeycomb less orderly. So if I take my car and try to go through this maze, I'm going to hit at different bumps here. And that's a clue that this is actually concerning. And this is, again, a representation of, one second, let me just, uneven nucleus spacing, where you can see that what I just described, the nuclei don't respect each other's borders or boundary and kind of create this collision here. And here, what helpful clue is seeing that mucin vacuole here that automatically tells you that this is pathology. And some more images of crowding and overlapping, and I'm sure this is something you all are very familiar in your practice. And anisonucleosis, and I think this is really, of all tumors that we know, pancreatic adenocarcinomas probably tend to show this consistently, anisonucleosis. And the ratio that the textbooks talk about is 1:4, and which means the nucleus size, like in this image on the right, can vary from 1 to 4 times difference within the same group. And this is such a helpful feature that we can use to, in addition to the drunken honeycomb, to differentiate well-differentiated adenocarcinoma of the pancreas or adenocarcinoma of the pancreas with GI contamination of ductal cells. Because GI contamination and ductal cells do not show this anisonucleosis. You do not see this in a chronic pancreatitis. This is pretty specific for adenocarcinomas. Single malignant cells, always helpful. So when in my experience, when I see large sheets of what looks like ductal cell groups, I really try to go hunting for those single malignant cells to reassure that this is actually malignant. Because in cytology, we generally know that anything that comes out as large groups, you want to really make sure that is this malignant or not, because usually malignancies tend to fall apart into smaller groups. So I use that a lot in my practice. I really look for single malignant cells to really try to nail the diagnosis of malignancy. So some of the examples. And this is just an example to show the irregular duct lumen that we're seeing in surgical resection, beautifully represented in a cytology image on the left with mucin vacuoles and so on. So if we have cases like this, it's so easy, right, to diagnose a case of adenocarcinoma, but sometimes the challenges can occur, and that's what we're going to talk about. So I don't know how many of you have experience with the liquid-based preparations. I think liquid-based preparations has created a new wave in the diagnosis of thyroid and pancreatic lesions. Liquid-based preparations specificity is pretty close to the conventional smears, and sensitivity is also fairly high, in fact, higher than conventional smears. And one could argue, why is this? It's very simple, because a lot of our interpretation on conventional smears depends on smear preparations, right? So how well the smear is prepared is how well we can interpret. What happens with liquid base is that it removes that preparation aspect of it. So literally you take the sample and squirt it into the, either thin prep vial or sure path vial or whatever you use, and basically spin it down, make a cell block, and look at the liquid base slide. So really there's not a lot of artifacts in relation to the preparation technique. And pretty much a lot of, there are cells stuck in the needle hub and everywhere else that we're not getting in the smears, and we can let it sit and get it to clot. And so if we are immediately able to put it in a thin prep vial, literally are capturing every cell that was caught in the sample. And by spinning it all down, we're actually capturing as many cells as possible. So we're not losing cells in the preparation technique. But again, it's a very institution dependent and pathologist dependent practice, but liquid-based prep has evolved to be a very useful tool. And so this is just an image comparing the conventional smear on my left and to the thin prep on my right. As you can see, the image is pretty identical, right? I think what tends to be harder to distinguish in a liquid-based prep is the background, because conventional smears still tend to retain, because of the smearing technique, a nice background if it's cystic or if it's necrotic, and that's very helpful in some lesions. Whereas thin prep, because of the way it's prepared, it's spun down and kind of the background just gets torn down so much. And also because of the preservation fluid, we're not able to see a lot of this debris material in the background. Nonetheless, it is, as you gain more experience seeing liquid-based preparations, one would be able to grasp all these subtle differences with these techniques and make a good call. Just showing you the various preparation methods. That, ideally in some practices, when they use liquid-based preparation, they probably do a liquid-based slide like on my left, and they may also get the cell block or with the Charcot on the middle, and that can be used for immunostains as well. So if one technique, you could probably get a lot more. Molecular wise, there's still, this field is evolving, but we have come a long way in trying to identify the molecular alterations in pancreatic adenocarcinomas. And some of the key driver genes are as I've highlighted, KRAS, P16, CDK, and 2A pathway, and P53 alterations, as well as loss of SMAD4. Pretty much KRAS is what we see in more than 90% of pancreatic adenocarcinomas with alterations in the codon 12. And the frequency of KRAS mutation progressively decreases as tumors arise more proximally. And I think that's a little helpful too. In cystic lesions, and we're going to talk about it, we're going to see a lot more GNAS and KRAS. I think these molecular alterations are largely helpful in mucinous cystic lesions in the pancreas. I'm not going to dwell on this, but these are some of the key alterations, and it's all there in your handout. And what's recently being a buzzword in pancreatic ductal adenocarcinomas are the microRNAs. And what are these microRNAs? These are nothing but small single-stranded non-coding RNAs that regulate the gene expression. They are non-coding, and that's important to remember. They can serve as potential biomarkers of pancreatic ductal adenocarcinomas, and that there are actually in industries using that, and some of the tests to highlight whether this is a high-risk cyst or not tends to use some of the microRNAs in their test modalities as well. Just a little bit about the well-differentiated adenocarcinomas. We talked about all these features and how to differentiate that from a benign ductal groups, and these are some of the examples. So you can see that take your car and go through the drive, and you can see you're going to hit along every single aspects, and that's your overlapping nuclear irregularity with overlapping and an isonucleosis that does it. And so this is very important to distinguish from a benign ductal group or benign GI contamination, as you can see in this image, where it's so orderly and nicely arranged, whereas adenocarcinomas, well-differentiated adenocarcinomas tend to have a lot more irregularity here. You can see that there's nuclei are small to large and have anisonucleosis. And every time a car tries to go through this, it's always hitting all sorts of speed bumps here. So that irregularity is what we're expecting in a well-differentiated adenocarcinomas. And another tool that goes across all malignancies is the parachromatin clearing, and that's nicely seen in this image where there's so much clearing right in the center. And some of the mimics are, as I mentioned to you earlier, GI contamination and benign ductal cells, but pancreatitis probably poses some of the biggest mimics for well-differentiated adenocarcinoma, and let's talk about it. So this is just to highlight ductal cells versus well-differentiated adenocarcinoma, and we talked about this. And this is how a GI contamination or the gastric fovea type epithelium looks in relation to well-differentiated adenocarcinomas. As I mentioned earlier, gastric epithelium is a cup-shaped epithelium, has a basal nuclei, whereas adenocarcinomas tend to be more high in C ratio and do have these nuclear alterations that we talked about. And this is duodenal cells in comparison with the well-differentiated adenocarcinoma. So chronic pancreatitis is challenging, even for an endoscopist. Why? Because it is hypoechoic, as like we see in adenocarcinomas, but there are some subtle features that do help if present, and one of those are calcifications. If we see calcifications in a mass, it's very helpful to say that this could most likely be a chronic pancreatitis. But otherwise, chronic pancreatitis do tend to show strictures and duct dilatation, just like adenocarcinomas would. So it's challenging for that reason, and also it's challenging for a cytologist unless you see all these features that I've highlighted here, which really helps one to think about chronic pancreatitis. So what are the features that we think about is the background debris, right? Chronic pancreatitis is nothing but chronic inflammation over time, saponification, necrosis, and the ongoing assault to the pancreas. So what does it show in the background? It shows what those exact findings. We see background kind of the debris-like material, the inflammatory debris with calcifications and crystals sometimes. And you also see the ductal cell groups exfoliate, but in very tight groups, right? It's very tight. They don't have a loose texture to these groups. And the ductal cells, you can see that the CAR can go nicely between these ductal cell groups. Although the nuclei is enlarged, they still respect their boundaries and spacing. And the nuclear membranes are round and retained. The background inflammatory cells and pigment really help. As you can see in this image, you can see the golden yellow pigment in the background and inflammation. So some of the other images of chronic pancreatitis, you can see in large groups of these benign ductal and acinar cells, and you can see inflammation and fibrosis in the background. And this is fibrosis in thin prep. But I have two images here, and one belongs to chronic pancreatitis and one belongs to well-differentiated adenocarcinomas. Can we tell that apart? No, not really. It can be challenging sometimes, although I've cheated here a little bit by only giving you a higher magnification. But as you can see, this can be rough. To my left is the benign ductal cells, which is reactive, and to my right is an adenocarcinoma. When we look at these images, yes, one may argue that nuclear atypia is more pronounced on the cell group on the right, and you can say that there's a lot more nuclear overlapping, and the CAR can really not go through this group rather than the other group. But still, these could be as, this cannot be easily distinguished, in a few cases. So just to highlight some of the differences, never call something adenocarcinoma without cellularity. Cells have to be there. It has to be a lot of cells in the slide to call it adenocarcinoma. So I do use these criteria to distinguish between chronic pancreatitis and adenocarcinomas. Chronic pancreatitis cellularity is variable, should not be as cellular. It should have a spectrum of cells in that it should have a mixture of ductal and acinar cells, in comparison to adenocarcinoma, which only can have like tumor cells mostly. And the background is so helpful in chronic pancreatitis. Always look for that inflammatory cells, look for crystals, look for pigment, look for some fibrosis, stroma, and calcifications in the background. And that's very helpful. Autoimmune pancreatitis, I wanted to touch upon this because when you see an aspirate that just contains benign acinar cell groups, and you're thinking, if this even a lesion, is the needle was in the lesion or not, it's important to discuss this with your endoscopist and also raise an important pitfall, which is autoimmune pancreatitis. Autoimmune pancreatitis can exfoliate largely as acinar cell groups, and it could be mistaken as acinar cell neoplasms, or it could be mistaken as non-diagnostic. There is no broadly accepted consensus criteria to diagnose autoimmune pancreatitis. It is always a diagnosis made on core biopsies or surgical resections or patient's clinical scenario. What we use as some of the criteria are these two, which is, these cellular stromal fragments, as you can see in this image at the bottom, where there's stroma and there is cells, and the cells are largely these lymphocytes and plasma cells admixed. And then you see acinar cell groups in relation to these cellular fragments. So if you see this kind of a background and this kind of image in your slide, then you can think of an autoimmune, but never outright diagnose it. You may suggest it because we don't have a consensus criteria for that. So some of the features we see, as we see here, are these acini. A lot of chronic pancreatitis, autoimmune pancreatitis tends to exfoliate as acinar cells. Why? Because there is loosening of the pancreatic centroacinar cells, which are readily aspirated. So a lot of what you're seeing in the aspirate tends to be more acinar cells in an autoimmune. So when you're seeing, my point to you right now is to just alert to this possibility that if you see a acinar-rich aspirate, and it looks largely benign acinar, and you're seeing inflammation in the background, you may want to suggest the thought of autoimmune so that they can just do some markers, or the patient may just benefit with steroids, and that's more than helpful. Other solid tumors, these are very important. Differential diagnosis is crucial, especially when you see solid cellular smears. So when you're seeing smears from a pancreatic aspirate that's just sheeting out and solid, have this differential diagnosis in mind: pancreatic endocrine tumor, solid pseudopapillary acinar cell carcinoma. The last one is pancreatoblastomas, which I have not mentioned because it's so rare. And obviously it's straightforward because you don't see it in an older age group, but rather in younger age group, and some distinguishing features exist. See, these are pancreatic endocrine tumors. We see that a lot in our practice. And nice neuroendocrine chromatin, salt and pepper, and various architectural patterns, and diagnosis is made by neuroendocrine markers. So in this case, when you're in an adequacy assessment, you absolutely would like to want to have a cell block aspirate, just to make sure we're not looking at an acinar cell or solid pseudopapillary, because they can overlap. So it's very important to have a cell block and stain them for neuroendocrine markers, like here, synaptophysin and chromogranin. One of the neuroendocrine markers we are now using in our practice is INSM1, which has been amazing, especially with limited samples. And this is just an image of pancreatic neuroendocrine tumor, single, very plasmacytoid cells, and they're sheeting out, which is very helpful in this diagnosis. Solid pseudopapillary tumors pretty much look very similar. Unlike neuroendocrine tumors, the nuclei may be more pale. They almost look like papillary thyroid carcinoma nuclei. They look very pale. There could be a lot of vasculature running through, but you can see that in neuroendocrine tumors as well. What is really helpful is also a cell block here and doing a beta-catenin stain. Again, the actinic cell carcinomas have such a morphologic overlap with these other two entities I just described, and therefore absolutely look for cell block. Actinic cell carcinomas tend to exfoliate as, again, like grape-like cells or clusters, and many of them tend to have bare nuclei in the background, a lot of bare nuclei. The cytoplasm can be granular to vacuolated with those purplish granules, but the background bare nuclei is very helpful. And sometimes you absolutely have to see the prominent nucleoli in these cells, which does not tend to occur in either solid pseudopapillary or neuroendocrine tumors. And you use the trypsin, chymotrypsin, and amylase stains to help differentiate actinic from their other counterparts. So just to drill the point home, these three are aspirate smears. And I'm pretty sure all of you are wondering which is which, because they all look fairly similar, right? So that's the whole point. So when you see solid cellular smears, in like this, which does not look like adenocarcinomas, introduce these three entities as a differential diagnosis. And just trying to differentiate that on a smear could be quite challenging. So, immunomarkers are very helpful, and I provided you a table to highlight these various immunostains that can serve helpful. So with that, and I'm just going to check, I think we have about 5 more minutes, hopefully. So I'm going to run through some of the pancreatic cysts. So pancreatic cystic masses, we do see, so important, this is all I want you to know. Pancreatic cystic masses, what's the most important thing to know about pancreatic cystic masses is that we are really concerned about mucinous cysts. Why? Because mucinous cysts are the ones that progress to malignancy and may have to be surgically managed. The remainder can be followed, right? So that's the main key thing. And so I'm going to only talk about mucinous cysts here because of that very same reason. So mucinous cysts, neoplastic mucinous cysts, what are the types of cysts that we see? We see IPMNs, we see intraductal oncocytic papillary neoplasms, or IOPNs, and we see MCNs, or mucinous cystic neoplasms, right? And cytology has a crucial role here. Mucinous cystic lesions tend to have variable amounts of what I first described in my initial slides, thick colloid-like mucin and cyst debris with variable cellularity. And when you see papillary fragments, you can favor IPMN, or when you see an endoscopic report with duct connection. They tend to be, in cytology, we diagnose them either as low grade, and where the nuclei are basally located, and apical cytoplasm and absence of nuclear atypia or background necrosis. So that is low grade. IPMNs, and I'm not going to dwell more on this, all of this is in your handout, so I'm going to really go through the cytologic criteria of IPMNs. And yes, IPMNs tend to be the main duct or the side branch, and it's very important to know this distinction because main duct has a higher risk for malignancy. Side branches tend to have lower risk for malignancy and predominantly are of the gastric phenotype. So, so this is in your handout, this is the international consensus guidelines for managing pancreatic cystic lesions. And absolutely important. So when you've been called mucinous neoplastic cyst, you have to absolutely see thick neoplastic mucin if it's low grade. Higher grade lesions may not show as much mucin as possible, in which you have to see, in which case you have to see nuclei with features of malignancy. All right. So this is a nice example of background mucin with papillary groups here, which tend to nicely show basally located nuclei, apical cytoplasm. So imagine this could mimic a GI contamination. What GI contamination does not have is a thick mucin in the background, right? And also remember, if this is a head lesion, this looks like gastric mucosa. So if it's a head lesion, it should not look like GI gastric. It should look like duodenum, right? Because that's how the needle goes. So that's what you use to distinguish. So these are nice papillary groups floating in a cell block. And this is the mucinous cytoplasm that we can appreciate in a low grade and so on. So grading is always an issue, and this is just to drill the point home, mucus only. And if you only see thick neocolloid-like mucin, you can call it outright neoplastic mucinous cyst. No neoplastic epithelium is present, and that's okay. This is just to distinguish between regular gastric fovea type GI contamination with IPMN. Always remember, in a mucinous cyst or a mucinous neoplasm, the mucin fills the cytoplasm all around, whereas if it's a GI, it's only apical cytoplasm, right? So look for that filling of the mucin all around. And this is just to show some more examples of low-grade dysplasia, where the nuclei is basically located, apical cytoplasm with mucin nicely filling the cytoplasm. This is another example of a high grade, where I'm just going to show you that you can see single cells with high NC ratio, almost malignant-like cells. And this, you have to look for these single cells if you see a cystic lesion with necrotic debris in the background. And this is how it looks, very high NC ratio, almost, these are single malignant cells. So this is an IPMN with high-grade dysplasia. So basically the needle went and aspirated a lot of these single high NC ratio cells, and that's good enough to call this high-grade atypia. So this was a surgical sample where you can see it was a nice papillary lining, and then there was this high-grade. So high-grade atypia cells are very small and tend to show all the malignant features that we described in pancreatic solid tumors, but with a largely cystic background and with an endoscopic report of a cyst and with sometimes mucin in the background or necrosis. So this is just a paper to show how small the high-grade cells can look, very small, almost the size of an enterocyte, but you can see the high NC ratio, nuclear membrane irregularity, hypochromasia, etc., etc. So these are the differential diagnoses for neoplastic mucinous high-grade. And the way how we report in cytology is you just say neoplastic mucinous cyst. If you see papillary fragments, you can favor IPMN, but always look for features of high-grade dysplasia. And if you don't find it, please report that you do not find high-grade atypia, and that's very important. I'm just going to this is just to show the difference. I'm just going to rush through MCN. Only one point I want to tell you about MCN is it's fairly similar overlap with IPMN on cytology, which is why we can't distinguish it on cytology. We have to see the ovarian type stroma that's only seen on surgical. But what helps me a lot in my practice is seeing these histiocytoid cells, which are nothing but mucin-filled tumor cells, which almost mimic histiocytes in MCNs. And I found this helpful. And if you see this, and if you see imaging reports of what looks like MCN and mucin in the background, you could suggest that. All right, so this is just to highlight some of those features on ThinPrep, and these are these muciphages that you see on ThinPrep. But always use all the information you get, the background as well. So this is just a nice image of those muciphages, histiocytoid-like cells, but these are actually tumor cells. It's just taken a lot of mucin in them, which is benign because it's very low NC ratio, and you can see them floating in thick mucin. And the malignant versions have malignant cells. That's a basic difference. And that's it. So all of this is in your handout. And we do cisfluid analysis when we do look for cisfluid CEA and amylase levels. And remember that anything with high CEA, the cutoff value most literature talks about is 192. Anything with a higher CEA, you do tend to introduce the idea of mucinous cyst. And anything with high amylase, you tend to think about pseudocyst. If it's a serous cystadenoma, it tends to be very low CEA and very low amylase, and that would be helpful too. And we do tend to use molecular as well, sometimes in case of challenging cases, especially for mucinous cyst, and especially if you see KRAS or GNAS, that is pretty diagnostic of a neoplastic mucinous cyst. And this is just a workflow that we tend to use in our practice, and how to approach the cytology, pancreas cytology, and I hope you find this very helpful. And thank you so much. And I apologize for running over time, but I guess, we're good to go now. So thank you, and let me know if you have any questions.
Thanks so much, Rema, and I believe Leslie is going to go through. There's a couple of questions, and if we could get those answered in about the next 5 minutes, I think we'll be fine on time. So Leslie, do you want to answer those, ask those? I think I have to unmute you. Give me 1 second. There you go.
Okay, thank you so much for that thorough talk, Dr. Rao. Okay, so we have a couple of questions.
Sure.
Let's see. One of them was about concerning using IgG4 immunos for the diagnosis of autoimmune pancreatitis, I believe.
Right. So yes and no. So IgG4, we have IgG4 is probably a helpful tool in diagnosing autoimmune pancreatitis, but there are IgG4 negative cases as well, which can be challenging. Many a times the clinicians have approached us with this particular distinction, in which case having a cell block in few of these cases have helped me a lot in kind of helping, trying to getting to that, at least suggesting autoimmune pancreatitis. So what I've tried to use is if I have good cell block material, I do stain for IgG and IgG4, and obviously seeing more of IgG4 staining over IgG helps me along with the clinical context that we discussed, imaging findings, if the patient has serum IgG4 elevation, to suggest that this could be IgG4. I use a lot of cytology, like I was suggested, acinar. If it's a very acinar-rich aspirate and it all looks like benign acini, and I'm seeing these, inflammatory cells in the background, then I would also think of IgG4 related disease. So yes, I do use it in cell block material. I do look for, prominent IgG4 staining, but I have to tell you, it's not very common or very easy to see that in daily practice. It's really because if we don't use a sharp core or some of those techniques, it's very hard to get a good material to do the staining. But yes, if you have core biopsies, feel free to stain for IgG4, but do look for the cytology characteristics as well, like the acinar-rich aspirates. And in cores, you do look for ductocentric inflammation. You do look for, phlebitis and so on, the other features. Yeah, I hope that's helpful.
Wonderful, thanks. Dan, do we have time for one more question or should we conclude? I don't know.
Go for one more, Leslie.
Okay, wonderful. Yeah, there's one other additional question. I think someone was seeking clarification on the approach to liquid-based preparation to the pancreatic sample. In the chat, the question was, does non-GYN or GYN procedure is applied for it, I think. And so if you could just sort of very briefly kind of go through, because I think the convention, right, is that we, do the conventional direct smears, but with the liquid-based, then that would be collected directly. You would have, if you perform on-site assessments, then of course you can do your rapid assessment. You can make your conventional smears, but then you would use the needle rinse to then put that into the liquid-based preparation. Can you take us through that really quickly?
Yes, absolutely. So just like how you mentioned, Dr. Lomo, so basically using, rapid assessment actually helps in this regard, because you don't want to keep looking at so many smears of carcinoma. You want to just look at the, 2 smears. We got the material, then you can take the remaining passes and use the remaining passes and just flush them down into a thin prep or SurePath vial. In our institution we use SurePath, and in the previous institution we used to use thin prep. So that's basically how it's collected. Some cases where rapid assessment is not possible, or it is after hours, we have encouraged the clinicians to send a sample directly on thin prep, and that's been extremely helpful for that as well. So what happens is these clinicians, especially if their needle is in the lesion and they're able to see that, they can just aspirate 2 or 3 passes if it's a cyst, or 4 or 5 passes if it's a solid tumor, and just flush all of it into just liquid based and send just 1 vial to our lab. And we tend to process it as thin prep or SurePath, depending on the modality, and then use the remaining material, especially if tissue fragments are floating, to process the cell blocks. So if we have the sample in a liquid-based preparation vial, we can do a thin prep or a SurePath, and we can do a cell block from the same sample. And so it's actually helpful in these cases. Does that help? Does that answer the question?
I think that covers it. It's clear that we are at a great time frame in terms of having access to a lot of information, radiologically, clinically. You've indicated your use of cyst fluid analysis. While that all of these modalities may not be available in every clinical setting, I think it's critical. You've emphasized very well how important the role of the cytopathologist is in helping to manage these difficult lesions, and that we are integrating more and more. And so hopefully for our audience, this helps pull things together and provides updates. So thank you so much, very much, Dr. Rao, for that comprehensive talk. And we will also have your handout for all of the additional materials. So appreciate that.
And this is, just to conclude, just to let everyone know, because Dr. Rao went through some of her slides a little bit quickly, we will produce a PDF of this document and share it with you. And that is our plan going forward for all of our sessions, is to share the PDF handout with you. So look for that in a follow-up email. And I think with that, Leslie, we can conclude. And I just want to thank everybody for participating. Thanks, Dr. Lomo, for organizing. And obviously, Dr. Rao, for a really wonderful presentation. And we will see you next month.
Thank you, everybody. Thanks for the opportunity. See you all. Have a good day.
Bye-bye.
Bye.